Hi, everyone. This is James McGuire. I'm a senior physician in the Division of Infectious Disease in the Department of Medicine at Brigham and Women's Hospital, and professor of medicine at Harvard Medical School. And I'll be presenting some challenging infectious disease cases to you. I have no conflicts to report. We'll just go ahead with the first case. This was a case we saw recently, a 72-year-old man who presented with fever, headache, and loose stool. Has a history of hypertension, but otherwise is healthy. And a week earlier, he spent 3 hours with a relative who went on to die from COVID-19. He was using appropriate protection. He had an N95 mask and whatnot. But days later, he developed sudden onset of fever, headache, loose stool, cough, no shortness of breath. He called his primary care physician. He reported he remembered removing a tick from his arm a couple weeks earlier and had a red rash around the tick bite. Primary care physician sent in an order for a nasopharyngeal swab for COVID, and was worried about Lyme disease because of the history of the tick bite and the rash, but did not prescribe doxycycline because there was a question of doxycycline allergy. He suggested the patient use a home oximeter, which he did. The O2 sat went down to 94%. His brother somehow got home oxygen, and he took some acetaminophen. The next day, he was still febrile, headache, slight cough. The primary care physician had gotten some blood work and showed a low lymphocyte count of 120. Fever went up further and recommended that he went to the emergency room. In the emergency room, he was ill appearing, febrile 103, oxygen saturation 96% in room air. His lungs were clear on exam. Weight count was 4,500 with low lymphocytes again, low platelets. His transaminases were elevated, and then his markers for inflammation that we look for in patients with COVID-19 were markedly elevated. His LDH, his CRP, D-dimer, ferritin, and procalcitonin were all up. His chest x-ray was clear. He was admitted to our special pathogens unit with diagnosis of possible COVID-19. So question for you, just to think about, anything else you'd be thinking about, any other studies that you would like to order? So he had some blood cultures taken. These were negative. A chest CT showed no opacities at all. We looked at his peripheral blood smear. He had low platelets, as we knew about, but now some atypical lymphocytes, but no intracellular parasites or inclusions were seen. Put him on doxycycline, 100 milligrams by mouth twice daily, and overnight he effervesced and started feeling quite a bit better. His swabs, the PCR test for SARS-CoV-2, were negative times several. Our clinical diagnosis was anaplasmosis. Studies for tick-borne disease had been sent. They came back. Lyme serology was negative, PCR and smears for Babesia were negative, but his PCR was positive for anaplasmosis. So he had anaplasmosis, and very, very much in the differential diagnosis of someone presenting with typical symptoms of COVID-19. And I think this is one of the conditions that we'll see more of during the summer months, and when we have to be on the guard against and keep in the differential diagnosis. This is a rickettsial-like bacterial infection transmitted by the Ixodes scapularis tick, the deer tick here in New England, but in the mid-central states and other places throughout the United States. And if you look at the presenting symptoms of patients with anaplasmosis, they're very much some of the same things we look for in patients with COVID. So fever, headache, myalgia, leukopenia. Cough is unusual anaplasmosis, but can occur, as can diarrhea. Diagnosis of anaplasmosis is typically a clinical diagnosis initially. You can do a blood smear, and if you see the morula, intracellular inclusions in granulocytes, that will confirm the diagnosis for you, but this is relatively insensitive. We confirm the diagnosis with either a PCR, which we did in our case, or serology. You can see a fourfold rise in IgG antibodies. We treat with doxycycline. Usually a week or 10 days is enough. We treated this patient with 14 days in case he had incubating Lyme disease. During pregnancy, we can use rifampin instead of doxycycline. And important message from this case is that empirical treatment with doxycycline before you have the results of the diagnostic test can be life-saving in certain tick-borne diseases, including anaplasmosis or Rocky Mountain spotted fever. So if you think of the diagnosis of a tick-borne disease, have a high suspicion, go ahead and treat before you get the diagnostic results back. Our next case was a 49-year-old woman who presented with fever, hypotension, and markedly elevated white blood cell count. A day before admission, she was perfectly well. She enjoyed excellent health. She developed a sudden onset of rigors, vomiting, and weakness. She noticed some red-purple lesions on both lower legs. She went to the emergency room locally. They did a blood count. They said, "We think you have acute leukemia." They got blood cultures, gave her vancomycin and piperacillin tazobactam, and sent her to our hospital. In our hospital, she was febrile, hypotensive, cyanotic, and she had these purpuric and petechial lesions on her legs, as you can see in the photo. Presses were started. Her white count was 79,000 with a marked left shift. She had 24% bands, you can see on the smear down below here. Hematocrit was 41, platelets were slightly decreased. Her transaminases were elevated, but renal function was normal. And blood smear, in addition to showing these immature forms, also showed toxic granulations, and then in the red cells, Hal Jolly bodies. She lives in the suburbs of Boston, no recent travel. She has a pet dog. So what's your differential diagnosis, and what should we do management-wise? Well, I think clue to the diagnosis, here's a patient presenting with septic shock who has Hal Jolly bodies on the smear. And Hal Jolly bodies are a marker of either asplenia or someone who's been splenectomized. And sure enough, CAT scan of her abdomen shows a trophic spleen. This was probably congenital. She vaguely remembers being told about it, but had no idea what it meant not to have a spleen. Her blood cultures returned positive for gram-positive cocci in pairs. So she had the syndrome of overwhelming sepsis in someone who was spleen deficient. And usually the most common organism is the pneumococcus, accounting for most of the cases, and then occasionally some other encapsulated bacteria, such as Haemophilus influenzae or the meningococcus. Also reports of this syndrome being caused by capnocytophagia, which is an organism, part of the normal flora of dogs, and so has been associated with dog bites. Rarely other cases of bacteria have been reported. Then, of course, we worry about intracellular organisms that infect red cells. So babesiosis and malaria can also cause life-threatening disease in people who are spleen deficient. In our patient, we were expecting pneumococcus, but to our surprise, the culture came back positive for Streptococcus galolyticus, subspecies pastorianus. And what is this? Well, this used to be called strep bovis, group D Streptococcus, and there's several different subtypes. This has been reported in other cases in patients with asplenia. In some cases, you can actually see the organisms in the blood smear stained with a gram stain, and any of the organisms causing this syndrome can be positive on a smear. And looking at electron micrograph, you can see that it has a small capsule. And so this is one of the agents that has been seen in this syndrome of overwhelming sepsis complicating spleen deficiency. Strep bovis, now Streptococcus galolyticus, when it occurs in the blood, we have to think about two other underlying conditions. One is endocarditis. We did an electrocardiogram on her and it was negative. And then the other is a lesion in the bowel, oftentimes in the colon, a malignancy or a polyp or other bowel lesion is associated. And so we ran her bowel as well, and this was normal. Treated her with ceftriaxone and she did well. And then the last part of her management was really to thoroughly go over with her the risk of asplenia in terms of bacterial infections and precautions to take to prevent this from occurring again. So she needs to be vaccinated with pneumococcal vaccines, both the conjugate and the polysaccharide, meningococcal vaccines, including for meningococcus B, Haemophilus influenzae, and she should get a yearly flu shot. She should wear a medical alert bracelet in case she becomes quickly ill and unresponsive. Be careful around dogs and other animals. If she travels to remote areas, she should carry an antibiotic with her, an empirical treatment course. I usually use levofloxacin. Other persons use amoxicillin clavulanic acid. She goes to an area where there's malaria. She needs to be protected with prophylaxis. She goes to tick-infested areas. She should either avoid them or make sure she doesn't get bitten by ticks. And you can find this information online. You can print it out and give it to the patients and review it with them. Our next case was a young woman, 22-year-old, who presented with acute onset of fever, and she had pain and swelling in her right knee. Previously healthy, taking no medications, but she was an intravenous drug user, and she was sexually active with a new partner. On examination in the hospital, she was febrile. Her right knee was swollen with an effusion. It was tender and it hurt when she tried to move it. She had 2 small pustular lesions on her left foot. Her white count was 14,500. CRP was elevated. Arthrocentesis were performed. There was a synovial fluid leukocytosis, 73,000 white cells, 93% were neutrophils. The smear was negative. So a question for you is, which of the following empirical antibiotic regimens would be appropriate for her? A, vancomycin, B, ceftriaxone, C, vancomycin and ceftriaxone, D, ceftriaxone and metronidazole, or E, combination of the 3? Well, in this case, correct answer would be vancomycin and ceftriaxone. Some people would actually, instead of ceftriaxone, use something that would include Pseudomonas coverage, such as cefepime or ceftazidime. But we're worried about her intravenous drug use and staphylococci and streptococci. And then we're also worried about sexually transmitted diseases, disseminated gonorrhea. Actually, what happened, she was admitted to the orthopedic surgery service. She was started on vancomycin, and she underwent arthroscopic lavage of the knee. The second postoperative day, the synovial fluid cultures came back positive for gram-negative diplococci. Blood cultures were negative, and cultures for gonococci of the cervix, urethra, rectum, and pharynx were all negative. Vancomycin was stopped, and ceftriaxone was started. Now, something that's unusual for disseminated gonorrhea syndrome is we don't often get positive cultures, either from the synovial fluid or the blood, although we can, but almost invariably there's a positive culture from the cervix or one of the other mucosal surfaces. It turned out that her organism was Neisseria meningitidis, so it was the meningococcus, not the gonococcus. Treated her with 2 weeks of ceftriaxone, that plus the washout, she made a full recovery. So the disseminated gonococcal infection syndrome is the most common cause of septic arthritis in teenagers and young adults. And typically the infection in the anal genital region of the pharynx is oftentimes asymptomatic. And patients can present with 2 syndromes. One would be tenosynovitis, dermatitis, and migratory polyarthralgias. That's seen during the early stage of infection when bacteria may be circulating in the blood, and there is a robust immune response. And then a second syndrome, trial arthritis, usually of a single joint or maybe 1 or 2 joints. The treatment for prion arthritis is evacuation, wash out of the joint, and then 14 days of antibiotics. We treat initially with ceftriaxone and a single dose of azithromycin, and then complete treatment with intravenous ceftriaxone. For the other syndrome, we can treat for 7 days, and we complete the therapy with an oral agent after the patient responds to intravenous ceftriaxone. But we have to test the organism and make sure that it's sensitive. Drug of choice would be something like cefixime. Of course, you want to test for syphilis and HIV. And message here is whatever we see with the disseminated gonococcal infection syndrome, we can also see with meningococcemia. And so keep that in mind, that this may be a surprise pathogen. Next case is that of a 67-year-old man who presented with a prolonged history of fever. Excellent health. For several days he felt sluggish, and then he had the onset of chills, lost his appetite, fatigue, and myalgia. He then develops fever to 103, drenching sweats. Seen by his local doctor, his white count's 4,300 with a normal differential except for an elevation of monocytes. SED rate is 16. Lyme disease is tested for and is negative, and blood cultures are negative. Chest X-ray and CT scan of the chest are unremarkable, and he's given a course of moxifloxacin and doesn't get better. Some more information. As I mentioned, previously healthy, works as a lawyer, lives in New Hampshire, grown children, no pets, no travel recently. This febrile illness went on for 3 weeks, and so then he's referred to us, and we admitted him with FUO for evaluation. Temperature is 102. He was fatigued. He had mild jaundice. You could feel his liver edge, but otherwise no adenopathy and no rash. He had a leukocytosis with a lymphocytosis, 60% lymphocytes, some monocytes. Platelets were 200,000. His SED rate was up. His CRP was up. Creatinine was high for him, 1.1. Transaminase is elevated, alkaline phosphatase and AST mildly elevated, but his alkaline phosphatase and GGT were markedly elevated. His bilirubin was elevated as well. So here's our syndrome: 3 weeks of fever, a lymphocytosis, and then chemical evidence of what sounds like a biliary obstructive picture. So what's your differential diagnosis? What else would you like to order? So we brought him into the hospital for work with a fever. We were concerned about the hepatobiliary tree and got an ultrasound. His spleen was slightly enlarged. The bile ducts were normal. We went down to the hematology lab and looked at the smear. He had an atypical lymphocytosis. And we started thinking of a mononucleosis syndrome. Serology for CMV and toxoplasma were negative. His HIV test was negative, but his heterofile was positive, and he had antibody profile for acute Epstein-Barr virus infection. His anti-VCA IgM was elevated. He also had an elevated IgG. Now, he's 67 years old. What was the source of mononucleosis in his case? Well, he had an 18-month-old granddaughter who attended daycare. And in the older population, those of us who can escape earlier life without acquiring EBV infection or CMV infection, one of the risks later in life are toddlers who go to daycare, become infected, usually have no symptoms, but can pass the infection on to grandparents. He got better. It took him a while. So the diagnosis was infectious mononucleosis with cholestatic hepatitis. And a few words about acute Epstein-Barr virus infection in older adults. Very few adults get through earlier life without infection, but about 10% may escape infection. And when they are infected, the illness is more severe than in younger persons. Less common to see the typical acute mono syndrome, so pharyngitis, lymphadenopathy, splenomegaly, but more common to see these prolonged fever, febrile syndromes, liver involvement, and jaundice. Our next case, this was a 39-year-old veteran with an 8-month history of back pain and a 20-pound weight loss. He described the pain as constant. It didn't increase with coughing or movement. It was present at night. Sometimes it woke him up at night. He had no constitutional symptoms, no fever, sweats, chills, no anorexia, cough, abdominal pain, diarrhea, or constipation, but he lost weight. No history of trauma. Past medical history was unremarkable. He'd been in Vietnam during the war, and he'd had travel for R&R to Korea. On exam, he was afebrile. He had low back tenderness. His liver and spleen were palpable, both extending a centimeter or two below the costal margins. He had a mild anemia. On his CBC, he had a monocytosis, just marginally. His SED rate was markedly elevated. His alkaline phosphatase was elevated, but other liver function tests were normal. His TB skin test was positive at 20 millimeters of induration. X-rays of the spine showed several lytic lesions with surrounding sclerosis. You could also see them in the scapula here, lysis and sclerosis. The ultrasound and CT of the liver showed very large hypodense lesions. Here's his bone scan also lighting up in the scapula. I'll show you the gallium scan, which fairly nicely shows these large areas that are not perfused, and these corresponded to the hypodense areas on the CT scan. Workup included a bone marrow biopsy and then 2 needle biopsies at the liver. These were non-diagnostic. They showed some chronic inflammation, but nothing specific, no organisms, nothing grew on culture. So he was sent for open liver biopsy. And what was taken out was a large area of necrosis with surrounding epithelioid cells, some giant cells, some plasma cell and lymphocytes, and a dense fibrous capsule. And this is what it looked like. So here's this area of necrosis in the liver. Here's the capsule, and at higher power, you can see the very, very mild infiltrate of round cells, and on close inspection, many of them are plasma cells. So any further studies you'd like to get, any diagnosis? And I'll tell you, this was a tough case. We presented it to one of the most brilliant infectious disease specialists I've ever known, Mort Swartz. He thought it was tuberculosis. Other thoughts were melioidosis from the time in Vietnam. But the diagnosis was made with a blood test, the serological test for syphilis. The RPR was positive at 1 to 8. The diagnosis was gummatous syphilis. This was a patient with multiple gummas from tertiary syphilis. He had had a history of gonococcal infection while he was in Korea. He had an LP. It was negative, nothing to suggest central nervous system syphilis. Got 3 doses of benzathine penicillin and very, very slowly over the months recovered completely. So gummas are a reflection of the vascular injury to tissue. And typically what you see in a gumma is a large area of necrosis, as we saw, and then surrounding chronic inflammation and fibrous lesions. This is what they look like in a gross specimen in the liver. This is not our patient. In the bone, you can see what corresponds to the lytic lesions and then some sclerotic lesions around that. The message in this case is syphilis is the great imitator. And you want to think about it even in cases when it's not the first thing that comes to mind. Next case was a young man who came back from a trip to India with fever. He was in excellent health. He'd spent 3 weeks in India. He went to Mumbai and then to Ahmedabad. He'd gotten there via Dubai. And a week after he came back from the trip, he developed fever, 103, headache, fatigue, and the fever went on for a number of days. He got some mild relief from ibuprofen and amoxicillin clavulanic acid. So that was his story, kind of undifferentiated fever after travel to India. And so one of the things to ask you is, what would you think of as you're walking to the emergency room? You've been given the quick history. What are some of your immediate concerns, things that you don't want to miss? And this would be important in travelers from tropical and other areas. So you want to think about infections that can be rapidly fatal. So things like falciparum malaria, typhoid fever, other bacterial septicemias, meningococcal meningitis, some of the rickettsial syndromes, hemorrhagic fevers. You also want to think about infections that could pose a risk to the public health. And so if you bring this patient into your emergency room, you don't want to infect other patients, hospital staff, or visitors. And so what are infections that require proper precautions? Meningitis, hemorrhagic fevers, measles, the Middle East respiratory syndrome. He had been in the Middle East. COVID-19, of course, nowadays, hepatitis and tuberculosis. In terms of differential diagnosis, in his case, we want to think of some of the endemic infections from where he's been traveling. And so undifferentiated fevers in travelers to the tropics include such items as malaria, dengue, typhoid fever, enteric fevers, rickettsial infections, which are largely in sub-Saharan Africa, African tick bite fever. We look at the different regions of the world, there's different risks for different pathogens. So sub-Saharan Africa, malaria is way up on the list. In Southeast Asia, dengue, and the same with the Caribbean, dengue. Here's South Asia, India. And so infections can be from malaria, they can be dengue, they can also be enteric fevers, are all things that are high on the list. The orange are mononucleosis syndromes, so things like CMV, EBV, or acute HIV. More history on our patient. He'd visited family and friends, stayed mostly in cities, but he did go out to the countryside. He wasn't sick during travel. He stayed in private homes. He ate at private homes, went to restaurants, ate street food, drank tap water, things he wasn't supposed to do. Reported many mosquito bites, but no animal contact, no fresh water exposure, no sexual contacts. Calling back home, nobody back home in India was ill. Before travel, he hadn't gone to a travel clinic, so he had not been vaccinated for hepatitis A, typhoid, Japanese encephalitis virus. He was taking no malaria prophylaxis. In the emergency room, he was a fatigued appearing young man, not in distress, temperature 101.5, pulse 88, blood pressure was 110/70, maybe a little low for him. Rest of the exam was unremarkable. White count was 6,000 with 15% monocytes. Hematocrit and platelets were normal. Liver and renal function tests were normal. Blood smear for malaria, no parasites. His chest X-ray was clear. He looked pretty well. He wanted to go home, so the emergency room staff discharged him, only to call him back hours later when his blood culture returned positive. What do you think of now? What's the diagnosis? Positive blood culture. These were gram-negative rods. Should we treat him empirically? Well, the blood cultures came back, as I've said, gram-negative rods. We put him on ceftriaxone. He developed hives, and the cultures, as now we were suspecting, were positive for Salmonella typhi. The susceptibility testing showed intermediate susceptibility to fluoroquinolones and resistance to nalidixic acid, which is a marker for quinolone resistance in Salmonella typhoid. So we treated him with azithromycin, and he did well. It's important to remember that typhoid fever from South Asia, but other parts of the tropics as well, there are increasing rates of antibiotic resistance, and the fluoroquinolones, which we used to rely on heavily, may not be effective. There's also some amount of resistance to agents such as ceftriaxone. A little about typhoid fever. The risk in South Asia is many times higher than the risk for travelers going to East Asia or Southeast Asia, to Africa, the Caribbean, or Central and South America. South Asia is really the hotbed of typhoid fever. And ideally, he would have been vaccinated. We have 2 typhoid vaccines available in the United States, the oral live attenuated vaccine, which gives protection that lasts about 5 years. And then the capsular polysaccharide vaccine gives you protection for about a year or two. There is a new vaccine, a typhoid conjugate vaccine linked to tetanus toxoid, not available in the US, but that may be the best of the 3 when it becomes available. Protection is not perfect and does not include paratyphoid fever. I think one of the messages from this case is when he was in the emergency room with the history that he gave in the travel, probably better part of valor would have been to keep him in the emergency room, more blood smears for malaria, and just to keep an eye on him because of some of the potentials were quite serious. Next case is a 6-year-old woman presents with a swollen right knee, fever, and a history of being ill for about a day or so. She'd had a total knee replacement 3 years earlier for osteoarthritis. With this history and presentation, she underwent arthrocentesis. The synovial fluid white blood count was 110,000. Smear showed gram-positive cocci in chains, and the culture returned positive for group G streptococcus. So here's a patient with a bacterial infection, a septic periprosthetic infection of a total knee replacement. Question for you, do we need to remove the hardware in this case to cure the infection? So this is a foreign body infection, and like other foreign body infections, there are certain properties to keep in mind. The pathogenesis is conditioning the surface of the foreign body with host proteins that allow the organism to adhere to the surface of the foreign body. The organisms that can cause foreign body infections then can produce a biofilm, an extracellular glycocalyx, a slimy layer that they hide within. They undergo metabolic changes. They slow down. They may not replicate, and are because of that are unsensitive to certain antibiotics. They're not sensitive to cell wall active antibiotics. They're also fairly sheltered from host defenses. So phagocytes can't get to them. Antibodies don't work so well, and they're just much, much harder. So foreign body infections typically are harder to treat than infections of the normal substrate. And in some cases, the way you get rid of the foreign body infection is you have to remove the foreign body. So in the case of total joint infections, the treatment options are, of course, antibiotics and then a number of surgical possibilities. Oftentimes, the procedure is what we call a delayed exchange, which entails removal of the hardware, treatment with antibiotics, observation off antibiotics, and then delayed reimplantation. In Europe, more commonly, a direct exchange is done where the infected prosthesis is removed, the site is cleaned, and then a new prosthesis is put in place. What about debridement, retaining the prosthesis, and either with or without suppressive antibiotic therapy? Can we get away with that? And that's the question for our case. Or in some cases, remove the prosthesis and don't replace it. So this is someone who's had his hip replacement removed. This is the Girdlestone procedure. Can manage, can get around, but you can't Girdlestone a knee. Then you have a full extremity. And so in the case of a knee prosthesis that's removed permanently, the options are fusion, arthrodesis, or amputation. So pretty drastic surgical interventions. Now, there is some literature on outcome of prosthetic joint infections treated with debridement, antibiotics, retention of components, and in some case, prolonged oral antibiotic suppression. This is a series from the Mayo Clinic of 100 cases or so of treatment where they did not remove the hardware. And they were successful in about 46% of the cases in this series. Almost 80% of these cases were streptococcal infections. When the organism was Staph aureus, they weren't successful. And in none of these cases of staph infection did they use rifampin. So in our case, she had group G streptococcus. She underwent debridement, washout, and liner exchange, changing the polyethylene. And then she got 6 weeks of intravenous ceftriaxone and then put on 6 months of amoxicillin and did extremely well afterwards. So we didn't have to remove the prosthesis. Now, had that been a staphylococcus, the situation would have been more difficult. And what we've learned in the past several decades is that we can actually get away with successfully treating staphylococcal infections without removing the prosthesis if we use rifampin. So these are cases in which the prosthesis is washed out, and then the patients are treated with intravenous therapy and then transitioned to an oral regimen containing rifampin. In this case, the second agent is ciprofloxacin. And in those patients who received rifampin did very well. Those who didn't had relapse of the infection. So in the case of these staphylococcal infections, if the patient's infection meets certain criteria, which we'll talk about in a second, we can opt for retention of the prosthesis and trying to treat with prolonged antibiotics using a rifampin-containing regimen. If they don't meet these criteria, then resection of the prosthesis is necessary. The criteria is that it has to be an acute infection, either acute postoperative or hematogenous, that you diagnose and act upon within several weeks. No sinus tract or problems with the soft tissue envelope, and the organism has to be susceptible to rifampin. The protocol is just as in our case, debride, treatment with intravenous antibiotics, and then a long course of rifampin-containing regimen. You can use a quinolone, trimethyl sulfur, doxycycline to accompany the rifampin. And if all these conditions are met, the cure rate is excellent, 80% or so in some series. If it's not met, then the failure rate is substantially high. Our next case is that of a 36-year-old woman with pain, swelling, and purulent drainage after breast implants and other plastic surgery procedures. She was previously healthy. She went to the Caribbean for plastic surgery. She underwent bilateral silicone implant breast augmentation, liposuction, bilateral buttock fat injection. And a month later, she developed pain, redness, swelling, and purulent drainage from the right breast, and then later from other sites as well. She had no fever, no sweats or chills, and her white count was normal. The other sites began to drain as well, and this is a photo of her abdomen. She's got a draining sinus, and you can see the surrounding erythema. She undergoes debridement and removal of implants and suture material and transplanted fat, and stains and cultures were all negative after several days. Question for you, what's the most likely pathogen? MRSA, actinomyces, nocardia, Mycobacterium, or Aspergillus? The answer is Mycobacterium. She grew out Mycobacterium abscessus in cultures after several weeks of incubation. The isolate was sensitive only to amikacin, intermediately sensitive to cefoxin, resistant to all the other antibiotics that were tested, including trimethyl sulfur, linezolid, moxifloxacin, imipenem, doxycycline, clarithromycin, and others. She had to undergo removal of both implants and debridements of all of her sites, and then we treated her for 3 months of amikacin and cefoxidin, and now 3 years later, she's done well. She was one of a small series of patients who had cosmetic surgery in the same clinic in Dominican Republic. If you look in the literature, there are now multiple outbreaks in different clinics and different overseas sites of plastic surgery procedures in which the surgical procedure is contaminated by atypical Mycobacterium. Mycobacterium abscessus is usually the offending organism, although other species have been identified as well. This is an environmental organism. It's ubiquitous in water, soil, and dust. Can be hard to treat. High rates of resistance is in our case, and you need very aggressive surgery. This is a well-described hazard of medical tourism. And so patients who are thinking about having less expensive procedures overseas need to be warned about these hazards. Next case is that of a 66-year-old man who developed low back pain after working in the garden. About 8 weeks after onset, he had worsening pain, didn't get better with bed rest. It was worse at night, no fever, sweats, chills, loss of appetite. He'd had a TUR 4 months earlier. On exam, he was afebrile. He had tenderness over the spine. His neurologic exam was normal. White count was normal, but he had an elevated SED rate. Cultures of blood and urine were negative. Question for you is, could this be infection? Well, a little bit of a crazy question since we're talking about infectious diseases. And so the answer is yes, it could be infection, but I want to point out this is a case of spinal osteomyelitis. And in series of patients with this infection, more commonly than not, patients may present without fever, without an elevated white count, and their only symptoms may be pain in the back of the neck. It could be an atypical pain syndrome, and the pain oftentimes is present for a number of months before the diagnosis is made. A helpful clue is elevation of inflammatory markers. Usually one or both are elevated in almost all cases. Next question for you is, which of the following x-rays is most consistent with the diagnosis of spinal osteomyelitis? So here we have a collapsed vertebrae. We have a punched out lesion in the vertebral body. And here we have this lesion where we've got erosion of end plates and loss of the intervening disc space. So a little bit about hematogenous osteomyelitis, of which spinal osteomyelitis is an example. In children, it's typically the long bones that are affected. And that's because the bone marrow is abundant in long bones. And typically in children, the site of infection is in the metaphysis, just below the epiphyseal plate, where blood vessels take a sharp turn. In adults, as we get older, our bone marrow dries up in the long bones, and it's primarily in the flat bones in the spine. And so most of the cases are going to be in the spine, or other flat bones, the sternal-articular bones, the pelvic girdle, and less commonly in the long bones. The spine, infection is bloodborne, goes to the vertebral body where it sets up infection near the end plate, very quickly goes into the disc space and into the adjacent end plate. So you get this particular pattern, which reflects very nicely what we saw in the x-ray, where you have erosion of end plates and narrowing of the intervening disc space. This is best seen on the MR, which is actually your imaging modality of choice for spinal osteomyelitis. And here you can see the vertebral body involvement, the disc space involvement, and then also paravertebral or epidural collections of pus or inflammatory phlegmon. Our patient underwent CT-guided needle aspirate twice. Smears were negative. They showed some neutrophils, but no organisms, and no organisms were isolated in culture. Treated empirically with vancomycin and ceftriaxone for 6 weeks, but at 3 weeks, he got worse. His inflammatory markers were still elevated, and now his MR showed he had enlargement of the paraspinal abscess. Underwent yet another needle aspirate. This time an E. coli was isolated, resistant to third-generation cephalosporins. Probably acquired that at the time of his TUR. He required debridement of the abscess, a long course of treatment with imipenem, and then he did extremely well. We think of spinal osteomyelitis, don't forget about spinal epidural abscesses. These usually occur in the setting of osteomyelitis, but can occur without osteomyelitis. The symptoms that make you think of an epidural abscess is pain followed by root pain, and then weakness below the level of the involved root, sphincter dysfunction, and then paralysis. These patients may require rapid surgical decompression. Depends on where it is and how big it is. So a big one in the neck needs urgent surgery. A small one below the takeoff of the cord could be treated medically. Final case is that of a 61-year-old woman with fever of unknown origin. Excellent health previously, except for history of gastric bypass surgery. She very slowly became ill with low-grade fevers and flu-like symptoms. She developed swelling and redness of her lower legs. She got a course of doxycycline for Lyme disease and got better, but then it came back again. She kept getting worse, fatigue, weakness, weight loss, low-grade fever. She had several courses of doxycycline and azithromycin, and with each course she got better, but then her symptoms returned. She developed congestive heart failure, was admitted to an outside hospital. She was confused and forgetful. They did an LP. She had a very mild but abnormal neutrophilic pleocytosis in the CSF negative cultures. Scans of the chest and abdomen were remarkable mostly for cardiomegaly, small effusions, some enlargement of the spleen. She had multiple blood cultures done. She had evaluation for connective tissue disease. This was all negative, workup for malignancy. Transferred to us, where she was afebrile, fatigued appearing. She had roused by bacilli. She had a 3/6 systolic ejection murmur at the base. She had 2+ edema, so she had signs of congestive heart failure. She was anemic. Her SED rate was mildly elevated. Liver function tests were normal. Albumin low, CRP markedly elevated, and multiple blood cultures were negative. A transthoracic echocardiogram was done that showed severe aortic stenosis and regurgitation, but no murmurs. So what should we do? I think you're probably thinking, let's think about endocarditis, and she needs a transesophageal echo, but because of her prior surgery, she couldn't have that done. So she had a cardiac CT done that showed a large vegetation on her aortic valve with perforation, and now she had severe aortic regurgitation. She underwent valve replacement, debridement of a root abscess. Pathology showed gram-positive cocci. Cultures were negative. We sent the specimen off to CDC for molecular studies, and it turned out she was infected with coagulase-negative staphylococcus. Treated her with antibiotics, and she's done well subsequently. She was a case of culture-negative endocarditis, and people who have culture-negative endocarditis, sometimes, such as her case, had previously received antibiotics that caused the cultures to become permanently negative. The microbiology techniques may be inadequate if we don't look for highly fastidious bacteria such as Brucella, Coxiella, Bartonella, fungi, Legionella, the Whipple bacillus, mycobacteria, nutrient-deficient strep. The Hayseck organisms, usually we pick up with modern microbiology techniques, but if old-fashioned systems are used, they may be missed as well. And then, of course, we want to think about non-infectious causes that give a picture of endocarditis, the non-bacterial thrombotic endocarditis we can see with lupus or malignancies. So this was a case of culture-negative endocarditis, and these are some of the organisms you want to think about in dealing with patients with this possibility. Well, those are the cases I wanted to discuss. Thank you very much for your attention.